consequences of it. So once we go for that, then these people will identify, they will be understanding it, and then we'll go for the management of it. Again, during management, we shall be guiding that what kind of management we shall be giving. So once we go for that, what various pharmacological treatments we are going for, various drugs which are there. Now we know various drugs which are there for the treatment of epilepsy. On that we have to, from that we have to select various drugs. Basically, people classify it into broader classes. The drugs which are acting either on sodium or calcium channels, that is, they act on this, and because of that they reduce the ion passage inside the cell, this positive charge ion, and thus they reduce the impulse production, chances of threshold potential and impulse. So this is one. Second thing is we have got drugs which are acting on GABAergic mechanism. They act on various places in GABA. We know about various drugs we have seen earlier during insomnia, also benzodiazepine, barbiturates, etc. There are many such drugs which are acting on GABAergic mechanism. Multiple places they are acting, either agonist or maybe improving the or inhibiting GABA transaminases, etc. There are many such mechanisms through which they are acting. Then there are drugs which are acting through miscellaneous or multiple ways. So there are various classes. Rishika, it will take time, beta. Okay. So this is how these drugs are classified. We have got various drugs. People classify it one more way, that is, there were some drugs which are very old. Some they were introduced in somewhere 1970s, somewhere in around 2000. Some are drugs which are available after 2000. And initially only these drugs were very popular, which were older one. Example, phenytoin, then primidone, etc. These were the older drugs. And later many new drugs they have come and they have established themselves. Again, I repeat that if you have got the profile of this drug or pharmacological details of each and every drug, then we can have a table that what are the difficulty, what are the advantages or disadvantages of these drugs, and accordingly it helps us to select the proper drug. So we'll go for that when we go for the this pharmacological treatment. So once we confirm the epilepsy, which type of epilepsy is there, and accordingly what can be the best treatment which is available as per the guidelines, for that it can be there. It should be initiated in the adults. On the in both cases, whosoever is there, the specialist should be recommending it, and accordingly the anti-epileptic drug should be taken. Then check out various things, whether the person is having any neurological deficit. Neurological deficit means we have seen earlier, like malfunctioning, we can say. That is, they are not properly responding to the stimuli. So maybe slow learning like things. So if it is there, then you check it, what kind of situations are there. Then EEGs are very clearly showing that it is epileptic activity and what kind of epileptic activity. The child, young person, adult and their family and carers, they know, they are made aware about it, and this seizures can be a problem because it's not easy. We have seen, or you can see if some YouTube videos are there, because of seizure the person can fall down, so it can be trauma, it can be injury. That is one thing. Second thing is during that period the person cannot work, family has to take care of that people. Particularly if they are prone, they cannot go on vehicle or something like that, because if suddenly this comes and they are driving some vehicle, then it can be danger, or some important machine. So all these things are there which has to be informed and guided to that. Then whatsoever diagnosis we have seen from all these diagnostic tools, whether CT scan, PET scan, EEGs, etc., whatsoever abnormalities are there, we are reaching to a conclusion that what kind of drug are there, and accordingly go for drug. Now example, we can see that example, sodium valproate is a drug which is one of the most widely accepted and used drug. But the problem is it should not be given to women or girls during childbearing potential. Even young girls who are likely to need treatment to their childbearing years. So we should not give, means all these females we should not give, because it has got a big impact on the fetuses, and it will remain in body for some time. Then it can only be given when other options are not useful or they are not giving any results, but then during that period the pregnancy should be avoided, and it should be very clearly mentioned. So like that, once we understand that these are the major drawbacks, then we can go for this, and accordingly we can go, or we can allow various treatments. Now what can be our strategies for that epileptic treatment? That is, we'll go for a single drug. Usually co-medication are means simultaneous medications are avoided until and unless we need it. But if there is a comorbidity, other disease is there, then we can go for additional drug whatsoever required. The best anti-epileptic drug is to be chosen on the basis of the given syndrome or type of epilepsy. It is not clear at the time of presentation. The decision will be based on the symptoms which are there. Then this once we understand one by one what are these drugs, then go for these anti-epileptic drugs. If one, usually we start with monotherapy, just like depression and all other conditions, we have seen that we are going for monotherapy. But if it is not there, then we are going for another, means we call it as a changeover. That is, first drug is not effective, we may go for the second one. Again, while going for second one, we have got care that either drug from same class, means example, earlier we have used the GABA receptor modifying agents, maybe benzodiazepine. Then first benzodiazepine is not working, we will go for another benzodiazepine, or like that. But otherwise, one more thing is done by people, that if it is there, we can switch from the class of drug, means from GABA to sodium or calcium channel, like that. So we can go. If the this anti-epileptic drug is not suitable, means it is effective but adverse effects are not allowing it to there, then we can go for a second drug, which is the alternative first line drug. We have got first line, second line drug for that, and then go for that what should the best drug is there. Built up adequate or maximum tolerated dose, and then slowly first drug should be tapered off slowly. Tapering off is very, very important, particularly in all CNS conditions, because the sudden withdrawal can cause withdrawal reactions or relapse of the situations. So we'll start with another drug which is alternative, which is the best, next to the best, or second best we can say, and once it is started, once it is stabilized, then we will slowly reduce the dose. Just a minute. हॅलो, हां, खाली ऑफिसमध्येच आहे सगळं, जा तुम्ही ऑफिसमध्ये, ते दाखवतील तुम्हाला. ओके. Then if this replacement is not working, then what we'll go for, what we can do is go for the addition, or we call it as augmentation, if you remember. Go for augmentation of that. Again, augmentation wise, there are reports that usually the augmentation should not be done from the same class, because when drug from same class is added, then it can cause, rather it can aggravate the adverse reactions, because both are competing for same mechanism. So then they may not synergistic, rather even they may not be additive, may not be antagonistic, but yes, example 1 + 1 action becomes 2 is additive, we call. 1 + 1 becomes synergistic, we call. Here it is 1 + 1 may become 1.5 or 1.8. Why? Because both are competing for same. So usually it is preferred that it is not there. If the second drug is not helpful, either the first or second drug may be tapered, and then accordingly again modification can be done for the third one. The combination therapy like adjunctive or add-on therapy, or what we told, that is the incremental therapy should only be considered when attempts with monotherapy are not resulted in the seizure freedom. This is very important. Our goal is seizure freedom, means the short-term goal should be reduction in the seizure incidences, and long-term goal is seizure freedom or total freedom from the seizure. If the trials of combination therapy do not bring worthwhile benefits, then treatment should revert to the again monotherapy, which has been proved most acceptable to the given patient. So this is the way we'll go for that. Another thing is, if problem are there with the compliance, example carbamazepine is there, then we'll go for control release carbamazepine. Why? Because this will be slowly there, number of doses we can reduce. So these are various ways by which we can improve the treatment, we can improve the situations. Now once it is there, we'll go for various drugs. Now suppose what kind of epilepsy it is. We have already diagnosed it. So it is a benign epilepsy with controtemporal spikes. Then this is what we can say gastute type of epilepsy. Okay, then in that case what we shall be doing? So here the first line treatment is a carbamazepine or lamotrigine. These are the first line treatments we will be giving for these patients where there are controtemporal spikes, then Panay-Aitopoulos syndrome or late onset child occipital epilepsy, that is we call it as a gastute type. So in that cases, when it is confirmed diagnosis, then our choice will be carbamazepine or lamotrigine. But if they are unsuitable or not tolerated by this patient, then we'll go for another drug like levetiracetam or oxcarbazepine, particularly to women or girls of the childbearing potential. This first of this treatment they are tried, then we'll go for other. Again, sodium valproate we are not going for the females because particularly in childbearing age we know that these are the problems, and levetiracetam is not cost effective because it was a new drug and it was under patent, so it cost has been too much. So where the cost is a constraint, then oxcarbazepine is a better one. If it is not suitable, if the first line is not suitable, then we'll go for the second line. Then we can offer, what are the second line? That is carbamazepine, then clobazam, gabapentin, lamotrigine, levetiracetam, oxcarbazepine, then topiramate. These are the adjunctive treatment, particularly where the sodium valproate is not preferred choice. We have seen in what condition sodium valproate we are not choosing. But if it is there, then we can add sodium valproate if it is a male patient and there is no problem. Then same we can have example carbamazepine, then clobazepine, gabapentin, lamotrigine, levetiracetam, oxcarbazepine, sodium valproate, topiramate. They can be added as adjunctive treatment to all the girls, all the boys or female who are not having childbearing potential. So here sodium valproate we can add easily, you can see, and only in cases we are not there. If it is not effective, then we have got a third one. There are many we have got, that is eslicarbazepine acetate is a newer drug, lacosamide, phenobarbital, phenytoin, pregabalin, tiagabin, vigabatrin, zonisamide. These are all the drugs which are used as a third this one. So this is how we will go for the treatment. So this is the first case, and we'll continue this pharmacological treatment in this condition. That is, whatsoever drug is found effective, we'll continue this where we have got the seizure free period, and we'll continue it for at least 1 year. Then we can try to taper the dose slowly, and again we get the continuous seizure free period. Then we'll continue, or we can reduce it So like that we can go, or tapering of dose if gives, then even we can reduce the dose. So this is there. The high level of vigilance, treatment emergent adverse effects like bone health issues or neuropsychiatric issues after various anti-epileptic drugs is there. In some patients there are suicidal thoughts and behavior are there. So we have to check it drug wise adverse effects, what sort adverse effects are there. If they are serious one, they are important one, then accordingly we have to take care about it. Either we should taper it off slowly and add another drug which is not having that adverse effect, or we can go for the total change in the dose if it is possible with that. The consistent supply is important, so the drug should be available, and it should not be this example. In brief, we can say that plasma concentration should be maintained. So may it be on the basis of availability at home, availability at medical shop, and the regular dosing. So for that viability, we should take care that a suitable quantity of the drug is available at every places, and the patient is able to take it. If not, then immediately that particular arrangements are made, because we know that if the doses are missed or skipped because of non-compliances, the treatment can become failed, and because of that it can make a problem. So adherence is very important in all cases. For that adherence, all various guidelines, or the pharmacist or the attending physicians can have the guidelines for them. So these were the first one, and this is maintenance treatment is same for all. Then the another type of epilepsy is childhood absent epilepsy, or we can call it a juvenile absence epilepsy. If you remember, we have seen it staring like phenomena, which is there. We call it as a absence epilepsy. We have diagnosed it by various ways. So for that, the first line treatment is ethosuximide to all patient, whether there are male or female, because it is well accepted. But if at all sodium valproate has to be given, it should not be given to the female of the childbearing age. Offer these drugs to this, because both are first line drug. Ethosuximide is the first, and sodium valproate is the second choice. If there is a high risk of the generalized tonic-clonic seizure, then sodium valproate should be given first. Again, if it is not unsuitable, we know that it is unsuitable in childbearing ages. So ethosuximide is the first line treatment if only absent seizures are there, and there is a chances of general tonic-clonic seizures in the patient, then go for the sodium valproate as a first drug instead of ethosuximide. And again, one has to take care that there is no childbearing age is there during that period. If this first line AEDs they are not effective, then go for the another treatment, that is combination of ethosuximide and lamotrigine as a adjunct treatment. If particularly if it is not a childbearing age, then go for sodium valproate and lamotrigine combination. Okay, so these are the important drugs for that. If it is again this adjunctive treatment or additional treatment is also not effective, or it is not tolerated because of some adverse effect, then go for the next kind of drug, that is clobazam, clonazepam, levetiracetam, topiramate and zonisamide, because these are the third line treatment. These drugs should not be offered during this condition, like carbamazepine, gabapentin, oxcarbazepine, phenytoin, pregabalin, tiagabine and vigabatrin. This drug, they are not to be added. Continuation of treatment, we know that the same treatment has to be continued, it should not be stopped, and the effective care has to be taken that the drug is available, the dosing schedule should not be skipped, and for that whatsoever care has to be taken at enough stock at the house of the person, and if it is check with the nearby pharmacy, and see that it is available, so that the drug is not skipped, because in all these CNS diseases it is a very big problem, just like antibiotic, if you remember. So this we know. Then next type of disease is a Dravet syndrome. Again, discuss with the epilepsy specialist, tertiary. It is happening particularly in patients in pediatric one. The first line treatment will be topiramate, in particularly where the sodium valproate is not there. Otherwise, sodium valproate, which is not having any childbearing this one situation. So these are the drugs. Then next is that if this sodium valproate or this is not, topiramate is not being effective, then go for clobazepam or stiripentol as adjunctive treatment. Again here, these drugs like carbamazepine, gabapentin, lamotrigine, oxcarbazepine, phenytoin, pregabalin, tiagabalin, vigabatrin should not be used, because they are not effective, or it will unnecessarily give false hints. Few more drugs are there, like cannabidiol is the drug, and it can be given with clobazam. So this cannabidiol with clobazam is recommended as an option treating seizure associated with this Dravet syndrome in people aged 2 years and older, only if the frequency of convulsion seizure is checked every 6 months, and the cannabidiol is stopped if the frequency is not fallen by at least 30%. So if it is not effective to reduce this frequency by at least 30%, we'll consider that it is a useless drug, and we should not unnecessarily treat it. So first 6 months whatsoever there, suppose number of seizures per week are there, their frequency in both way we are measuring the number of seizures per week or per month, and the what is the number of minutes and per episode, how much it is there. So once we understand this, then we should see that if the drug is not able to reduce, that is cannabidiol is not able to reduce the symptoms by 30% after that combination, then there is no use of that. Okay. So it can be done accordingly. Cannabidiol again should be used very carefully, because it is from cannabis alkaloid, and the chances of abuse or habit forming can be there. Then next type of disease, which is very common and more one, it is generalized one, that is tonic clonic seizure. So the first treatment is the only is lamotrigine if for the women and girls having childbearing age. If they are not having, then first line will be sodium valproate. So these are the first line treatments. Then this can be given to anyone. If not, then additionally we can have, that is carbamazepine or oxcarbazepine. But this carbamazepine, oxcarbazepine can cause exacerbation. I hope you remember. They causes exacerbation of myoclonic or absence seizures. So that care has to be taken, because if these chances are not there, and if the previous two treatments are not successful, then one can go for this. Otherwise, these two are best, that is what we have seen, that lamotrigine and sodium valproate. So adjunctive treatment, we can offer clobazam, lamotrigine, levetiracetam as adjunct treatment to these people. That is example, sodium valproate plus lamotrigine, or lamotrigine plus clobazam, or levetiracetam. So only again, this is very common. See, you can see that how consistently NICE guideline is writing about this, that it should not be used. Sodium valproate, although is a good drug, is effective in most of the treatment, but even it is a first line treatment, except in the women and the girls in the childbearing potential, because it is having very high score of this, we can say, teratogenicity and genetic toxicity to the offspring. So these are these things has to be kept in mind. The clobazam, then lamotrigine, levetiracetam, sodium valproate, topiramate, they can be used. These are the drugs for when it is not a childbearing age. This is what the treatment. Continuation, already I told you, the continuation is same treatment, and we have to see that it is, once it is found effective, it has to be continued. Then idiopathic generalized epilepsy, in that what we are going to do is we can offer sodium valproate. That is the first line treatment. Again, exception is there, and if not, then what other drug are there? That is lamotrigine is there. Then if only thing is lamotrigine can exacerbate myoclonic seizures, and juvenile myoclonic epilepsy is there. It can also be used carefully. Consider topiramate, but see that it has got less favorable side effects profile than lamotrigine. Means lamotrigine is comparatively having less adverse effect and more acceptable features than this topiramate. If first line treatments are not working, then what will be the next treatment? That is, we can combine it as an adjunctive treatment, that is lamotrigine, levetiracetam or topiramate. Then or we can add it to sodium valproate, because sodium valproate is a first line drug. So lamotrigine, levetiracetam, sodium valproate or topiramate, these are the 4 drugs which can be used. Sodium valproate only will not be used in that particular condition. Then if adjunctive treatment is also ineffective or not tolerated, then go for the experts and can consider the clobazam, clonazepam or zonisamide. These are the drugs which can be used as a tertiary one, or the third line of treatment, or third choice of the treatment. In this patient, we are not going to offer carbamazepine, gabapentin, oxcarbazepine, phenytoin, pregabalin, tiagabine and vigabatrin. These drugs are not to be given because they can exacerbate other kind of adverse effects, and therefore they are not the treatment of choices. Today, after 2 to 3, one more lecture I have got. How long it will take? So exactly at 1:55, 10 minutes after you can come. Other book are in that room, I have kept. Yes. Then next is the infantile spasms. So get the guideline from the specialist. We can offer a steroid like prednisolone or terracoxactide or vigabatrin as a first line treatment, which are having infantile spasm, which are not due to the tuberous sclerosis. It is one of the problem. And it should be used very carefully, because the steroids are having their own big side effects. Although this is just most probably these are because of the inflammations. So we can reduce the inflammation, or we can use the vigabatrin in these conditions. But both are having their own toxic or adverse effects, and accordingly we can take care about it. Then next is juvenile myoclonic epilepsy. Again, sodium valproate is a first line treatment, and along with that first line treatment are lamotrigine, levetiracetam, topiramate. These are various additional treatment. First treatment is sodium valproate. Where it cannot be given, we can give any of these like lamotrigine, levetiracetam or topiramate. When it is not working, then we'll go for a combination of again these three or these four rather, lamotrigine, levetiracetam, topiramate and sodium valproate. This can be combined. Already I told you about how the combinations are made. You know mechanism of action of each and every drug because you have studied it in pharmacology, though you have not submitted it as a assignment, but I am very sure all of you are knowing it. You have studied it well, and on that basis you know various mechanism of action. So one guideline already I instructed that it is not preferred when combinations are there or augmentation is there. We do not prefer augmentation with the same kind of drug, that is from the same class or same mechanism of action of drug, because there are chances of rather increasing the toxicity, and no that much addition is not there, so it is not a very good addition. So preference is always, or it is given that, or even various level of evidences and class of recommendations shows that it is always better to have drugs from different classes as a combination. So accordingly we can go for different classes drug for combination whenever the first line treatment, in all cases whatsoever we have seen so far or whatsoever we shall be seeing after that, in all cases we shall be seeing this. The lamotrigine, these all drugs are having 4 drugs are there, and only we understand what is the specific contraindication to valproate, so we will not use it. We should in that case, if it is even this combination is there, then the third line is there, that is clobazam, clonazepam or zonisamide. These are the third line treatment which are available. Do not offer carbamazepine, gabapentin, oxcarbazepine, phenytoin, pregabalin, tiagabin or vigabatrin to these patients. Okay. Then again we can continue the same treatment which is showing effect, because already we have proven it, we have confirmed it. Therefore either first line or combination or the third line we are going to use, and once it is there, once we stabilize the patient, then just make it as a follow-up treatment, have the reviews on effectiveness and adverse effect of the drugs. So once we monitor it, this is what monitoring is required. Once the monitoring shows that the drug is effective, or you are getting the seizure free period elongation or zero seizure period, then we can consider what to be done. Then we can again check depending on the various kind of conditions. Then next is Lennox-Gastaut syndrome. So go for that. Again sodium valproate is one of the drug of choice, and where sodium valproate is not to be given, then we can go for another drugs like filbamate, lamotrigine. These are the important drugs which can be given. Even rufinamide and topiramate, these are also very good drugs which can be given as a third line treatment. So these are there. So the first line treatment is sodium valproate and lamotrigine only. Then as I told you, second line are these treatment are rufinamide and topiramate, and the third line is there, that is filbamate. So these are various treatments which can be given to the patient if it is there. We cannot give the drugs like carbamazepine, gabapentin, oxcarbazepine, pregabalin, tiagabin or vigabatrin. These drugs are not to be offered in that condition. Then next is cannabidiol, can be given with clobazam. Again earlier we have seen about cannabidiol, and check it, go for that. And again, if that particular same criteria is there, that is 30% reduction is not achieved additionally, then it is useless, and then stop that cannabidiol. Take care about the cannabidiol and accordingly go for it. Then in case of other epilepsies, we have variety of epileptic syndromes, and accordingly we can go for the treatments like these are various treatments, and then we can this epilepsies, and we can use any of the anti-epileptic agents which are showing effects into this. So these are the various epileptic situations, and accordingly we are going for that. So we have seen how we are going for diagnosis. On the basis, yesterday we have seen some of the things, that is depending on the focus, depending on the conduction, depending on the EEGs, we have classified them into generalized, partial, and accordingly we are going for that. We have seen then we reached to the management of epilepsy, and we went for pharmacology. Then at the end of during pharmacological, we have seen the treatment, and on that basis what are various treatment we are there occurring in that cases. Then another conditions are there like the partial type of seizures are generalized tonic-clonic seizure. We shall see this type of seizure in next class, additional seizures type and the treatment for that. So on that basis, this is how the algorithms are made in NICE guidelines. You go on clicking with each and every step, and you will get some of the text about it that will help you to understand this. Unfortunately, they are making the modifications simultaneously, and that helps in having latest drug knowledge also. So try for that, use it. Or actually there is one this epilepsy society is there, which is this International Epileptic Society is there, which is taking care about guidelines, and even NICE guidelines are referring these rather interactive are there, both societies, that is NICE and this International Epilepsy Society, both are using the data from each other, studies from each other, and on that basis they are improving the guidelines one after another. So these other guidelines we shall be seeing in our next class. If you have any difficulty, you can put it in the meanwhile.